Hello, everyone. This is Tavish Donahue from Healthier Here. I'm our Senior Practice Transformation Manager, and it's my pleasure to welcome you to Healthier Here's Partner Learning webinar for September. Today, we are going to be talking about the Healthcare Authority's new Substance Use Disorder Consent Management Guidance. Me personally, I work with a lot of our behavioral health and SUD partners, and I constantly hear about the challenges of managing SUD consent. So in response to the needs of our King County community, as well as folks statewide, we are thrilled to have folks from the Healthcare Authority presenting on today's webinar to share this latest guidance to really help you navigate that complicated system around 42 CFR Part 2. So to get us started, I'm going to talk through some logistics about how you will ask a question, because during today's webinar, we encourage you to ask questions as they come up. So the best way to ask a question is to type it into the questions box. So you can see on the screenshot, the orange button with the arrow expands and collapses this view. We will come back to raising your hand. But once you've expanded this view, you can type your question into the questions box. And when you hit send, it goes directly to me. So it doesn't go to anyone else. It just goes to me. So I will communicate with you back and forth once our presenters have started. So that's the best way to ask a question. And during pauses in the presentation, I will jump in and ask your questions for you. Another way to ask a question is to speak it out loud. So I mentioned raising hands. So you can see that little blue button right here with the hand symbol. So if you click that, I get a notification saying that you're raising your hand. And once you do that, I can communicate with you directly, and I can also unmute your line. So right now, everyone's lines are muted, per the default controls of the GoToWebinar system. So if you have a question and you'd rather say it out loud than typing it in, first things first, make sure you're connected via phone call and that you've entered your audio PIN. So if you've connected via phone but you haven't entered that audio PIN, then I'm not going to be able to unmute your line for you to ask a question. And generally, as a best practice, the phone audio is better than the computer audio. And entering that audio PIN connects both your accounts, since you're logged in on your computer as well. So that is how to ask a question out loud, but we do prefer that you type in your question, because it's a little bit easier to manage. Okay, so we are going to kick things off with a question for you. We have a poll in our system. So our presenters from the Healthcare Authority, who I'm going to introduce in just a minute, they're interested in knowing what you feel is the biggest barrier to sharing substance use disorder SUD information. We know that you're probably experiencing many barriers to sharing SUD information, but if you could select kind of the top barrier off this list for us, that would be great. So we're going to give you 4 choices. Number 1, there's no clear common understanding of 42 CFR Part 2. Number 2, SUD providers may not be able or willing to ask for consent from patients as part of a standard workflow in those patient visits. Number 3, physical health providers don't want to receive 42 CFR Part 2 information. And number 4, there's a lack of tools to facilitate that information exchange. Some examples of potential tools could be a shared consent management solution, interoperable health record systems, or a shared consent template. So now I'm going to launch the poll, and if you could answer, that would be fantastic. Just bear with me one moment. Okay, so our poll is launching. What is the biggest barrier to sharing substance use disorder information? And I can see responses coming in now, so we'll give you a minute or two to make your selections. Okay, looks like almost 70% of you have voted, so we'll give you another minute to get those votes in. We actually want to make sure your answers are reflected. Okay, some last responses are still coming in, so let's give that another minute. Okay, so I think we have some consensus in your responses. So I'm going to close the poll and you'll be able to see the results. Okay, so now you can see the full poll results. So 51% of folks on the call today said the number one barrier to sharing SUD information is no common understanding of 42 CFR Part 2. Yeah, the second most popular response to this question was lack of tools to facilitate information exchange. That had 36%. Then SUD providers not able or willing to ask for patient consent due to workflows, that was 10%. And then 3% of you said the number one barrier was that physical health providers don't want to receive that Part 2 information. So thank you so much to everybody who participated in our poll. So I'm just going to switch gears a second and pull up a new slide deck. Okay, so now I'm going to ask our presenters if they could unmute their lines. It's Healthier Here's pleasure to have Amber Sexton, who's the Washington Healthcare Authority's Data Governance Manager, on the line, as well as Matthew King, who's the Privacy Officer for the Washington State Healthcare Authority. Yeah, Amber and Matt, would you mind introducing yourselves?
Sure, Tavish, thanks so much to you and Healthier Here for having us today. We're excited to talk about the consent management guidance and solution with you and your community. We'll be starting with a short video, and then I'm going to turn it over to my colleague to talk about what we hope to cover over the next hour to hour and a half with you all. And as Tavish mentioned, please do feel free to interject with questions throughout.
Great, thank you so much, Amber. So now I'm going to pull up the video that she is referencing.
Hi, my name is Sharisa Patinos. I'm the Deputy Chief Medical Officer for the Washington State Healthcare Authority. I'm a family medicine and addiction medicine physician and have helped sponsor this toolkit. 20 years ago, most people thought addiction to drugs or alcohol was a choice, a weakness of character. This thinking led to discrimination and a law enforcement-focused approach to treatment. In order to protect people from discrimination, strict federal privacy rules were put in place. While well-intended, the rules are complicated and hard to understand. This has led to barriers in sharing important health information across different disciplines of care. The very good news is that today there are effective medical treatments for opiate use disorder. There are also behavioral therapies that can help people with other substance use disorders. This toolkit is meant to help medical, mental health, chemical dependency professionals, and patients understand how a person's information can be safely shared and protected. In order to better manage the whole health of a person, which includes their mental health, their substance use disorder history, and their physical health, better sharing of information needs to occur across healthcare disciplines. Substance use disorders are medical conditions that are treatable. Perhaps when healthcare providers become better at asking about substance use and sharing this information with other health-related disciplines, there will be less shame and trying to keep hidden treatable conditions.
Okay, so now I'm going to go back to our slide deck. Yeah, and I hope everyone could see and hear that video clearly. There might have been a little bit of a delay, but we do have the link embedded in our slides. There we go. Yeah, so the link to that video is on slide 2 of our packet, and we'll be sending that to you after today's webinar. Okay, so here is the agenda for Amber and Matt's presentation today. So I'm going to kick it back over to them, and just bear with us a moment while we transfer controls.
Okay, can everybody see my screen?
Yes.
Okay, great. Thanks, Tavish, for having us and for showing that video. I always like to start off with that because it's a little, it's a good compass for why we're doing this work. Amber and I, as we have been going down this rabbit hole for the past year and a half or so, tend to really get into the weeds and like to go back to that every once in a while to remind ourselves of what the ultimate goal of this work is. We have quite a bit that we'd like to cover today, starting with just a really brief overview of what 42 CFR Part 2 is and what the some of the issues are that have made it difficult to implement. We're going to then talk a little bit about the consent management work that we undertook about a year and a half ago, and the process that we went down that involved, I think, many people who are probably on this call today, and then talk a little bit about the actual resulting guidance that has now been published and how we hope it can be used. After that, we're going to go back to 42 CFR Part 2 itself and talk about how the regulatory scheme has been changing over the past couple of years and go through both the changes that were made in 2017 and 2018, as well as some common questions, and then finally a little bit about a notice of proposed rulemaking for further changes that was just very recently issued. And then we're going to wrap it up by talking about consent management technology. So at the beginning, we want to talk about understanding why we're talking about consent being needed for coordinated care, and to really just give a high-level overview of the privacy laws at the federal and state level that apply to this kind of information. And I need to just take a quick pause to acknowledge that although I am an attorney, none of this is legal advice. So with that out of the way, what we most commonly hear about when we're talking about privacy laws is HIPAA, which sets the floor for protecting information. And HIPAA generally allows any healthcare information to be freely shared for treatment and care coordination between providers and other people who are involved in a person's care. But it also allows other laws to come in that are more restrictive and set more stringent standards for how that information is handled. And probably the most stringent set of other standards that are out there is 42 CFR Part 2, which applies to certain substance use disorder treatment information. So on this slide, you're seeing just a very basic depiction of how this operates in real life, which is if you have a person who has a substance use disorder and they receive treatment from their physical health provider or physical health providers, those providers can freely share all of the information that they gather with each other to make sure that they're really treating the whole person and understanding the whole range of conditions affecting that person. But when that same person sees their substance use disorder provider, that information ends up being siloed and is not part of that whole picture that is shared with other providers, because 42 CFR Part 2 requires explicit consent for that information to be shared with other providers, and it's not a general consent, as we'll talk a little bit more later on in this presentation, and also as you'll definitely see in the resources that the Healthcare Authority published, there are some pretty restrictive requirements about what has to be in that consent and how it's gathered and how it is maintained over time. There are definitely other restrictions that 42 CFR Part 2 imposes. It's not just this care coordination piece, and the guidance does go through not all of those other restrictions, but a lot of them. But the main focus and the piece that we really wanted to pay the most attention to and try to move the ball on as much as possible was this care coordination piece. It seems like that is certainly the most urgent need that we are hearing from the community. So we started with the poll about about common barriers in implementing 42 CFR Part 2, and I know that we started a little cold with that, and some people probably have more expertise than others, but I've heard all 4 of those examples and many others as being common barriers. But I wanted to just highlight a little bit about how this work started and what we were really hearing from partners out in the community about what's going on with implementing Part 2 right now. One of them is just that Part 2 is very confusing to providers. It has inconsistent understanding, or people have an inconsistent understanding or just don't have an understanding, which can often lead to people over excluding information, so treating it more protective than they need to or that they should, based on just not understanding the law. On the other end of that, we also heard examples of people not understanding that the law applies at all, which could lead to information being freely shared when it shouldn't, which also is not good for the person who is receiving services, especially if they're aware of this law and they think that that information is being appropriately protected. So we kind of heard examples on both ends of the spectrum there, and neither of them had good outcomes. And then we also heard stories about the practical problems with implementing this standard. Even if you had a perfect understanding of how the law works, that there aren't consistent methods out in the community to actually facilitate sharing. So there aren't shared resources as people highlighted in the poll. So we have, for example, many organizations that have gone through the effort of creating consent forms that are totally compliant on their own with the law, but you end up with dozens and dozens of different forms, and every time one comes in, there has to be a legal review to determine if it's compliant, which can certainly stall the actual exchange of information. And then probably on a bigger scale, an issue is just that there isn't a centralized way to share the consent itself and manage what is shared with who. And there also are interoperable systems to facilitate the actual exchange of that information, even if you have the consent management part under control. And then the last one is just about burdensome requirements for the providers who are asking for consent, that we recognize that there's a lot going on when a person arrives to receive treatment, and there's a lot already going on in that clinical workflow, and just having this extra piece that is hard to manage and not often understood, it can also be a barrier to actually facilitating the exchange of this information. So I'm going to turn it over to Amber to talk a little bit about how we organized these barriers into different types of gaps.
Great.
Okay, and Matt, before Amber starts presenting, we do have a couple questions that I'd like you to field. And they both kind of concern the kind of nexus of mental health and SUD. So the first question is, do mental health providers have specific regulations, or do they follow HIPAA only?
Sure. So mental health information has its own protections in state law, and that's in Chapter 7002 RCW. So they do have something that's more restrictive than HIPAA, but 42 CFR Part 2 would not apply to that information.
Okay, great, thank you. And the second question is, if a covered entity provides both mental health and SUD treatment to a client, are those records considered separately covered, or do they both fall under 42 CFR? And along those lines, can a mental health provider be interchanged with the physical health provider?
So we're going to talk a little bit more about that, but I will later on, but I will foreshadow that that is one of the most complicated aspects of implementing this law. The short answer is that it's only the information that identifies that the person is receiving substance use disorder treatment that's protected. But when we have facilities that are treating co-occurring disorders, it can be very hard to actually segment that information.
Okay, thank you.
Thanks for those questions, and I hope that we'll get into a deeper dive on those use cases as we continue. So as Matt talked about the current climate and situation that we're in, we initiated this journey as through the lens of a governance and change management initiative in which we classify the current situation through these different buckets, and so that we can better target our activities moving forward. So we've addressed these in the poll, and that was interesting to see that those were consistent with what we found in our initial assessments with the stakeholder community. As you all identify, there's no common understanding of Part 2, and that fits under that people pillar. And then that last one, that technology pillar, identified that lack of tools is also a barrier, and there's a lack of harmonization amongst the tools that exist. There's also that center pillar, which is policy and process. So at the time we initiated this journey, there wasn't a standardized guidance that communities could follow, and there also wasn't a standardized consent form that utilized the HIE designation. And I won't get into that here, but we'll talk about that a bit more when we talk about the consent itself. So as we continue throughout this presentation, we want to talk about how a standardized consent management process and tools can address these specific barriers. And now I'm going to turn it over to Matt to talk about, how did we get here and where is that current situation and the history behind it?
Yeah, so before we go any farther, I do want to acknowledge the particular history of Part 2 and acknowledge that it was certainly created with the very important thought in mind of wanting to protect people from the risk of stigmatization and to avoid a result where people were avoiding treatment out of the risk of harm occurring elsewhere in their lives with employment or with their housing. But the reality today is that when we talk about this regulation, if they don't know about the history of it, they often point out that this doesn't make sense or how did we get here? And the reason is that when we think about the way that healthcare works today, it's very different from how it worked when this law was originally passed. So the legislation that underlies 42 CFR Part 2 predates HIPAA by about 25 years. It was originally passed in 1972, where there weren't other privacy protections in place for health information. The rules were finalized in 1975 and then got significant updates in 1987. There was a slight update not reflected on the slide in 1995, but effectively from 1987 until 2017, there weren't any updates to this law. So healthcare obviously changed a lot over those 3 decades. The last time that the rules were updated before that, we didn't have the concept of moving towards integrated care. We weren't consolidating payment systems and healthcare delivery systems. Health information exchange wasn't a thing at the time. In 1987, Windows was just becoming a thing, and they were just becoming comfortable with the idea of having multiple windows open on a computer page at the same time. But recently, we've seen this start to change. In 2017, we had the first significant updates to the rule in 30 years, and we'll talk a little bit more about that later on in the presentation. And then they were updated again in 2018. In both of those rounds of changes, there were widespread calls for further alignment with HIPAA and specifically to get rid of this consent requirement to allow providers to share information with each other. And the response from SAMHSA has consistently been that they can't go any farther because it requires a statutory fix. In 2018, when the federal government was considering a comprehensive opioids package, there actually was a statutory fix that was presented and passed fairly easily through the House of Representatives, but it ultimately stalled in the Senate, and it was actually one of the last things up for debate before that package was finalized, and it was left out. In light of that, SAMHSA went back to the drawing board and started considering additional changes to make, and they originally announced they were going to issue new proposed rules in March of this year, which did not happen, but they did recently, just at the end of August, issue new proposed rule changes, and comments on those proposed changes are due at the end of October. And we'll talk a little bit about that later as well. But the main point of walking through all of this is that the laws are outdated. They've been changing slowly, but the change has been slow, and nobody has a significant amount of faith that it's going to be changed anytime soon. I think for a long time, people took a wait-and-see approach, and we're hoping that there would be a change at the federal level. And increasingly, we're realizing that that might not happen. If it does, that's great. I think we're all going to be well-positioned to implement whatever the changes are. But for now, we can't wait any longer, and we need to do what we can within the current regulatory scheme. And that's really what pushed us to start this work. And with that, I'm going to turn it to Amber to talk a little bit about what this work is and the guidance that we've developed.
Great, thanks, Matt. So this slide is a description of the development path for guidance. I wanted to provide some context on the process that we utilize to get to the guidance in the toolkit. So as Healthcare Authority was hearing from diverse provider populations and through other programs and areas of work pretty consistently that there was a lack of consistent interpretation for Part 2, and this was a real barrier to integration, something that was of high importance to Healthcare Authority in 2017 and 2018 as we're moving towards integrating behavioral health. And we decided to initiate a cross-agency work group. And this was largely because as Matt and I were handed this project, we realized that we were not the subject matter experts on this. We wanted to include others who were involved in implementing healthcare across the state. And so you'll see through the development of the guidance, we also leverage a broader stakeholder community. But initially, we involved partners such as Department of Health, DOC, LNI, OSM, DSHS, and OSPI to ensure that we were building broad use cases that we would then use to evaluate and build the guidance from. We met with some key decisions pretty early on, and there'll be further discussion around this. But this desire to have a flexible consent form that could be used in diverse patient or healthcare settings and customized based on the provider needs, but also be able to be optimized for patient choice. We also wanted to incorporate recent SAMHSA updates. And as we talked about earlier, have this North Star focus on clinical care coordination. This is largely due to the high focus and value of the integrated care. We weren't the first state to undertake this. And California, several years back, developed what's called as the SHIG, or the State Health Information Guidance, sharing behavioral health information in California. And they focused on the broader behavioral health umbrella, and we did a more targeted focus on substance use disorder information and 42 Part 2 in the development of our guidance. The guidance was developed iteratively. So if you've had a chance to review the guidance itself, it's pretty lengthy, and there's pieces of it that can be pulled apart, but we realized early on that it was daunting to develop this from start to finish and then go out for review to the stakeholder community. And we wanted to make sure that it was useful and on point. So we felt the best way to do this was develop it almost section by section and then get that out to the stakeholders and community to evaluate and provide guidance on, and so that we could incorporate those changes and ensure that it was useful for those in the healthcare setting. We'll talk about those stakeholders next. The guidance itself was then finalized through this iterative development and review process in late 2018, early 2019. So this is a slide that displays that iterative review model. So as you can see, in addition to the cross-agency work group, we also had AHE and our Deputy Chief Medical Officer included in that initial review. As those sections were reviewed internally. Then they would go out for what we called stage 1 external review, which included professional associations, provider and payers, a sample from that population, and tribes and other Indian healthcare providers. After that next stage, they would go on to what we called our stage 2 external reviewer, which is a really diverse, broad stakeholder group, including MCOs, PHOs, ASOs, ACHs, and patient advocacy representatives. I'm sure that some of you on the call participated in that review cycle, and really want to thank you for your participation. What evolved from that iterative review and feedback cycle was a document and toolkit that can be immediately leveraged by the provider community, and hopefully not just be a resource that collects dust on the shelf. So as we were going through this process of development with the work group, we first had to focus on what were our guiding principles. And you can see here that some of the principles identified are well aligned, such as harm reduction and integration of physical and behavioral health, and some are seemingly conflicting, such as scalability and feasibility and patient control and specificity. But nonetheless, these were all identified as important to contemplate and consider as we develop not only the guidance, but the consent management solution moving forward. So as a result, from that iterative development and review process and special consideration of our guiding principles, we addressed the gaps that were identified earlier on in the project and developed a toolkit. So we'll go through each of the key deliverables from that toolkit, and they are all available on Healthcare Authority's website, and we'll make sure that you have a link for that as well. So in addition to the legal guidance, it includes real-world scenarios, a script for providers to aid their consent conferences with their patients, a brochure that can be used to aid those consent conferences, a form that's customizable and also scalable to a consent technology solution. And we also have, you saw a video at the top of the hour. There's, I think, 3 other videos that do a deeper dive into some of the more complex sections of the guidance. And with that, I'm going to turn it over to Matt to start to introduce some of the guidance.
Thanks, Amber. So we're going to do just a quick overview of what is actually in the guidance document, which is, as Amber mentioned, available on the HCA website. And if you don't have a link, it's pretty easy to find. If you just search for HCA consent management or something along those lines, it'll be your first result. So the guidance document is broken up into some sections, I think, that will hopefully make it a little easier to apply, even though it's worked or is created as one large document. Most of these sections will stand on their own. So when we're talking about the scope and summary of privacy laws, we just wanted to set the stage, not just about 42 CFR Part 2, but at least give a general nod to the other types of laws that apply to healthcare information. So, for example, there'd be more information in that section about the protections that apply to mental health information and how that's different from the protections that apply to substance use disorder information. There's some guidance that's generally applicable regardless of what type of information you're handling. So the concepts of minimizing access or disclosure of information to the minimum amount necessary, and the concept of de-identifying data. And then we get into really the details of 42 CFR Part 2, starting with who is subject to it and what information is protected. So that's where you would find more information about that co-occurring disorder question and what happens when a person is receiving services for both mental health treatment and substance use disorder treatment. Then we talk about disclosures with consent, giving a very detailed description of what is required for a valid consent and what the restrictions are once the consent is granted, and then also doing a section about uses and disclosures without consent. We often talk about how you need consent for everything, and that's the focus of this work, but there are certainly some scenarios where you actually don't need consent to share this information, and we wanted to make sure that those were clearly laid out as well. So one of the first sections or the first significant substantive area of the guidance is about who's subject to 42 CFR Part 2. And I just wanted to highlight that we were trying to come up with usable resources whenever possible. So obviously, this stuff is complicated. Sometimes it takes a long narrative to explain exactly what's going on and to explain all of the variations. But wherever we could simplify that into something more usable, we did. So this is just one example of a decision tree that's included in the document to walk people through whether they are or are not subject to 42 CFR Part 2. And I imagine to some it may seem pretty obvious. Certainly under HIPAA, people tend to know very quickly if they're a covered entity or not. But our experience has been that with 42 CFR Part 2, it's often a much more complicated analysis, and people aren't really sure whether they're covered or not. Another section that we included that I think was really important for us is to take all of the guidance and, again, sort of that narrative text and turn it in to more usable scenarios of changing kind of the description of what does the law say into how does that actually play out in real life. And the way that we did that was by creating an imaginary universe with a person who is being treated for a substance use disorder and the various types of people or organizations that might be involved in that person's care. So this obviously isn't going to have all possible examples, but it's not hard to imagine that that person would have contact with various providers who have nothing to do with substance use disorder treatment, like their primary care physician, or if they present at an emergency room. They may receive services from different types of substance use disorder providers who want to share information with each other. They may want to coordinate that care through community-based organizations. And that information also may need to be shared with other people the person doesn't have a direct relationship with, like third-party payers or other contractors of the providers that the person does have a relationship with. And once we had that kind of general universe created, we created a number of scenarios of how those different people would share information with each other and whether consent was or was not required for that sharing and what other types of protections might apply. So this is just an example of one of those scenarios, and this is an example for medical emergencies, which is one of the situations where you actually don't need explicit consent as long as the rest of the requirements and the regulations are met. So you'll see that each scenario starts with this kind of general format with the key takeaway, showing how the information would be shared and how the people would speak with each other. It includes a description of exactly what that scenario is, some helpful tips under the remember section in the bottom left there, which is really just memorializing some of the trickier things that we came across or that we experienced when we talked to people about actually implementing the law in these scenarios. We then have a more detailed description of the particular conditions in 42 CFR Part 2 that are required, that have to be met to allow the sharing. And then in the bottom right there, we have a section titled HIPAA in Chapter 7002 RCW, and that's just acknowledging that even though we're talking about substance use disorder information, that doesn't, and the protections are more protective for that, that doesn't mean we get to ignore the rest of the laws that apply. So you always want to make sure that any requirements in HIPAA or in state law are also satisfied. So we tried to distill that in that section as well. One of the other main sections deals with consent and really consent templates, and I'm going to turn it back to Amber for that piece.
Great, thanks, Matt.
And Amber, could I ask a question before you get going?
Of course.
Okay. So one of our partners in King County asked, with buprenorphine being increasingly prescribed by primary care providers, do they consider themselves to be SUD providers? Kind of where do they fall in the continuum?
So that is a very commonly asked question, but the answer to that is they are probably not going to be subject to Part 2, but it depends on how they handle their practice and whether they're what's called hold themselves out as being a substance use disorder provider. So SAMHSA has issued guidance that the fact of getting a waiver to prescribe that drug in like a PCP setting does not alone make that provider subject to Part 2. But if they do other things, such as working in an identified substance use disorder program in a facility, or if that becomes their primary function, then they probably are subject to Part 2.
Great, thank you.
Okay, so focusing on consent, this was one of the pieces of the guidance that took the most time, and you might be surprised when you look at what the deliverable is. I'm happy how I think clean and simplistic the form came out, but there were many decision points that went into that that clean, simple document. So first, at the start, we had to include the 9 required elements of consent defined in 42 Part 2, and we wanted to ensure that there was a nice flow to the consent form. So we tried to kind of group these together as we could. So, administrative information, and then who can exchange the information, and then what information is exchanged and why. So even though there's 9 elements of consent, it's really kind of 3 basic areas. So here's an example of one section of the consent form, and this is contemplating who can receive the information. I think this is a good example of how the consent form was built to optimize choices for the provider and the person seeking services, as well as provide a foundation for a scalable technology solution. So you'll see here there's multiple choice options, which is a requirement of 42, making sure that the person seeking services has choice when they're consenting. So the first option is consenting to all current, past, and future providers who have a trading relationship with the person. And this was pretty new and something we didn't see in a lot of the other consent forms that we evaluated when creating the guidance and the consent form. We thought this was really important to include, and Matt will talk about the general designation in just a moment. We also wanted to allow for either providers who weren't utilizing an HIE or persons who are comfortable with consenting to that broader access to be able to complete the more traditional model. And you've probably seen a table similar to this in maybe your consent forms or other templated consent forms. And then an option for both. This was an ask from the patient advocacy group. So we worked with the group to ensure that this is hitting the right note with person seeking treatment. And what was important to them was the ability to identify providers that they have worked with or who they wanted to share with, even if they were comfortable with consenting to an HIE. So we wanted to add the ability for both. Another area of the consent form, and I hope you do take a look at it, that we have multiple options is regarding consent expiration or length of consent. I think we have 3 options there, one which is an open text box, one which is a 1 year after date of signature, and then one is for the duration of the person's life, so it's date of death. And again, this form can be customized based on the provider's current limitations on the ability they have to monitor consent. So if they don't have the ability to have persons select kind of an open text box and write any date they want, they can work with the patient excuse me, on pre-filling that to a standardized date. So we, excuse me, what we hope is that the consent form, it can be used as is or can certainly be customized based on the provider's ability to manage that consent. And we do advise that if you're customizing the consent, to seek legal guidance to ensure that you're keeping all those compliant pieces within it. But we want the consent form to be immediately usable. So another part of the toolkit is the provider script. And this was, for me, one of the more enjoyable deliverables to work on. So we worked on this with Dr. Fontinos, and we acted as we were the person seeking treatment, and she was the provider, and she was guiding us through the consent conference. And we recorded that interaction, and we worked with her on editing that, ensuring that it was hitting the right tone. And what we really came out of that was that she was providing a non-judgmental environment for that consent conference and in her initiation of that consent. She was setting the clear intention for improved patient care experience and that whole person care, and also working with a person on supporting a self-directed decision making. And so I really encourage you all to take a look at that as a tool that can be utilized if you don't have a high comfort level with initiating this conversation with the people you work with. Obviously, it's just a tool, and you know your clients best, so please use it as you desire. And then one other bit that we included in the toolkit, and similar to the consent form and the provider script, these can be, I think these are saved as standalone documents, so they can be printed from our website and used in the clinic right away. And this is similar to what you would see in a clinical research study or a HIPAA brochure, and really informs the people seeking treatment on why you'd be collecting consent, what's involved in consent. We also have a kind of a placeholder at the back of the brochure that you could place your specific contact information if they have questions. So we really wanted this to be immediately usable in the clinical setting as well. And this was another one of those pieces that we worked heavily with patient advocacy groups to ensure that we were hitting the right note. So now I'm going to turn over to Matt, and I'm going to get to this is the part that you guys are all most interested in. So what are those recent changes to 42 Part 2, and what are those common questions? So some of those have come up during the session, and so Matt will hit on those and address some new ones as well.
And Matt, before you get started, do you have time for a question from the audience?
Yes.
Okay, great. So we have a number of community-based providers on the line. So the question is, are providers of non-clinical providers of long-term recovery support subject to Part 2? And as an example, of recovery cafes.
That is a good question, and to be honest, that's not something that I had considered before, so I don't have an answer ready to go for that. I think that what would be critical to look at in exploring that would be going back to the definition of a Part 2 program, and specifically thinking about what it means to be what they call a program, and it has some requirements about receiving federal assistance, for example, is one prerequisite. And so that's where I would direct people to, but I don't have a response off the top of my head. Okay,
no problem. And we just got another question. So for consent for multiple parties, would the client need to fill out a new form when a person within their previous parties changes if they didn't choose option 1?
So rather than go back to option one and the form that we created, I think I'll try to just answer that more generally. Anytime, or a consent form can list as many parties as the person wants to list on it, but what's important is just to make sure that they are contemplated there, and not just that the person is contemplated, but that the purpose is the same purpose, and that the information being shared matches up to what that purpose is. So, for example, you couldn't have a single form that lists a third-party payer and another treating provider, and then says like the purpose is to receive payment. You would want to have separate forms for those functions. Amber, do you have anything else to add on that?
Yeah, well, I'm just going to ask you another clarifying question, because how I heard the question was, if someone were to consent to a provider at a particular practice, and a new provider joined that practice, and or they started to see another physician within that practice, do they need to sign another consent form, or can they list the practice or the facility rather than individual providers?
I see. So the guidance actually has a table in it that walks through exactly when you need to list a specific person versus just being able to list an organization. So it would vary a little bit depending on how you fit into that kind of matrix that's laid out in the regulations. If the person had selected a general designation to share with all treating providers, then that would cover all of the treating providers, because they only had to give that broad designation. You don't need to go into the level of detail of listing specific providers.
Okay. So what I'm hearing the answer is to look in the guidance. Just a teaser answer.
Great, thank you both.
So all of the guidance reflects the law as it exists today. So it includes the changes that were made in 2017 and 2018. But I did want to walk through some of the recent changes, just to give a sense of the types of changes that have been going on, and also because I know some people have been around this for a long time, and it takes a little while to catch up to the fact that things have changed, and what you learned 5 years ago isn't necessarily what the law is today. And then also go through a couple of common questions, although I will admit we have already hit most of them, so I think that part will be pretty quick. So in 2017, as I mentioned at the beginning, we saw the first big round of changes in 3 decades, and this is just a quick summary of the types of changes that were made. So they changed the definition of program and holds itself out, which was an attempt to clarify that question about who is actually subject to Part 2. And I think that is something that has been tweaked several times over the past decades, and is something that is going to continue to be an area of emphasis, especially as healthcare evolves and the different types of people and organizations that are involved in care continue to evolve. We're going to continue to see SAMHSA try to identify and provide guidance about who exactly this law applies to or doesn't apply to. The second bullet here, titled Modifies to Whom Requirements, is really one of the probably the most significant change that we've seen. And what it was is a change from previous requirements that required you to list exactly who you're going to share with. So like a specific provider, and not just, and I guess I should say one specific provider. So you could list, maybe 5 providers, but you have to list each of them individually. And this was a change to allow what people now call a general designation, where instead of listing out those 5 providers, you can just say, I consent to share my substance use disorder information with all treating providers. So this isn't necessarily a silver bullet. You still have to gather the consent. It still needs to be managed over time. It still has all kinds of complicated factors. You still have technology questions about how do you implement that, but it opens the door at least to some creative solutions to try to effectively manage this. If you imagine a person who comes in to receive substance use disorder services for the first time and they're asked to sign a consent, it's not very likely at that point that they're going to be able to list all the providers they want their information shared with in the future. They might not even know who they are yet, let alone have them with them at that moment. And allowing this general designation is a workaround for that. It allows the person to acknowledge that they're okay with their information being shared with all of their providers in the future. SAMHSA also made some changes about when information can be disclosed in response to an emergency, which you saw the example of in that scenario we walked through. They changed the standards for disclosures to what's called a qualified service organization. So for anyone who's not familiar with that term, it's similar to the concept of a business associate in HIPAA. What we're talking about here are the contractors of providers who are subject to Part 2 or other people that get Part 2 information, like third-party payers. So just like under HIPAA, those people can have contractors that do certain types of work for them, and they can share that information with those contractors without getting specific consent. They changed the research requirements to align more closely with HIPAA, although we'll say not exactly with HIPAA. And then they changed, or this isn't really a change, but they specifically acknowledged that the consent could be electronically signed, so you don't have to maintain a physical signature on that consent form. After those changes, there were widespread calls for additional changes in alignment with HIPAA, and in 2018, there were more changes. So SAMHSA again clarified the ability of lawful holders to share with contractors. So lawful holder is just a term for anybody who receives the information other than the actual provider. So if it's shared with a third-party payer is the easiest example. That third-party payer isn't a Part 2 provider, but they are lawfully holding the information, and they're effectively subject to Part 2. They clarified the ability to disclose for audits and evaluations without specific consent, and generally those audits are allowed when they're done on behalf of a governmental organization that has some oversight responsibility or on behalf of a third-party payer. And then they made a change to allow an abbreviated notice of the prohibition on redisclosure. So what this is when somebody signs a consent form and their information is shared with somebody, that actual information has to have a statement that goes along with it that puts the person receiving the information on notice that it's subject to Part 2 and that they can't redisclose it. And I can't remember, I haven't counted for a while, but I think the old requirement was approximately 100 words long, and they now allow you to put that kind of 100-word explanation or this shorter statement that's about 10 words long that just says in plain English, this information is subject to Part 2. So again, it shortens the requirements, but it's not a very significant change in the sense that you still have to provide that statement along with the information. So I'm going to turn to some of the most commonly asked questions, which has been proved by the fact that they've already been asked today. So the first one we have here is, does 42 CFR Part 2 apply to all substance use disorder information? And the answer to that is no. Just like HIPAA only applies to health information that's held by covered entities, like providers and payers, 42 CFR Part 2 only applies when it reveals that the person receives substance use disorder treatment and when it's kind of obtained or originates with certain types of specific providers. The next question gets at that what we already heard about in terms of what happens when somebody is receiving treatment for co-occurring disorders, or when there's a provider who treats a broad range of or provides a broad range of behavioral health services, including mental health and substance use disorder services. So Part 2 doesn't necessarily apply to all records created by a Part 2 program. So if you are a provider who certainly is subject to Part 2, but you also treat people for, or you also provide mental health services, if you have a patient who's only receiving mental health services, that information doesn't become subject to Part 2. The next one we also hit on pretty explicitly. Does Part 2 apply to a primary care physician who prescribes buprenorphine? And as we already talked about, the answer is probably not. And the fact of getting that waiver and prescribing buprenorphine alone isn't going to make the physician subject to Part 2. Another question that comes up is what happens when a person shows up for an appointment with their primary care physician and they self-disclose that they have a substance use disorder, or they self-disclose treatment information, or maybe they actually even get a copy of treatment records from their SUD provider, show up at their PCP and hand them the copy of those records. In that case, where the person's self-disclosing it, none of that information is subject to Part 2. I also answered this one, can a consent form list more than one recipient? Although I think I maybe misunderstood the question a little bit. But the answer here is yes, a consent form doesn't have to be limited to just one recipient. It can be broader than that. Before we had the ability to have general designations, where you would see this most often is people trying to document all of their treating providers by name. I think an area where we now see it more frequently, or at least where I see it more frequently, is when you have multiple organizations involved with kind of the oversight or payment for services. So, for example, we may have consent forms that list behavioral health administrative services organization and a managed care organization and the healthcare authority all on one form, because they all may have an interest in sharing information related to either payment or kind of general healthcare operations. And this one is about can a consent form allow disclosure to all treating providers? So this is really the example of that general designation that we already talked about. And as I already went over, the answer now, since 2017, is yes, it can, but there are specific requirements that come along with it. And the way that the regulation contemplates that you would do this is that the consent would actually be managed by some type of intermediary. Here it's in this example, it's a health information exchange. It could also be like an accountable care organization, but somebody that's managing the consent. And then that kind of intermediary is the gatekeeper to share information with all treating providers. So the consent form would need to list that the information is going to be shared with that intermediary, the HIE here, and that the HIE can then share with all treating providers. Another condition that comes along with this is that HIE has to be able to provide a list of all the people that it's actually shared information with back to the person if they ask for that. So it, as I already mentioned, it does potentially streamline things and present a path forward to allow greater sharing, but it is not, it certainly certainly not a clean solution, and it still has lots of conditions attached to it and is difficult to implement. So all those conditions and kind of the different ways and variations where this can happen in practice also are outlined in the guidance. So the last thing I want to touch on in this section is just a quick acknowledgement of the proposed changes that are live right now. So these are changes that came out just in August. Comments are due on October 25th. The Healthcare Authority and other partners are currently working on our comments, and feel free to reach out to us if you have any questions or thoughts about this. But wanted to go over just kind of again a high level review of what these changes are, and it's especially interesting, I think, to see that many of these are iterations of what we already saw in 2017 and 2018. So that when we just look at the high level overview, it looks pretty similar to what already happened. So one common theme in the proposed rulemaking is an attempt to clarify how the law applies to non-Part 2 providers who receive substance use disorder information. So as Samsa explained in the preamble or in the introduction to this proposed rule, they are hearing that there are non-Part 2 providers who don't want to receive this information out of fear of becoming subject to Part 2. And so they proposed a series of changes that make it a little clearer when that information that's shared with the non-Part 2 provider is or is not subject to Part 2. So an example of those changes are that if a person signs a consent form, the Part 2 provider calls a primary care physician and gives them some basic maybe medication type and dosage information, and the primary care physician takes notes based on that verbal conversation and takes those notes in their own treatment records, that those treatment records aren't subject to Part 2. And so there are a series of changes that are along those same lines. They're also doing further alignment of the research requirements in Part 2 with HIPAA. So earlier I said the law was changed in 2017 to more closely align with HIPAA, but not completely. The proposal now is to completely align it, so we have the same requirements of when information could be disclosed for research purposes as people are familiar with in HIPAA. The next two are changes that would explicitly allow the disclosure of information to central intermediaries and kind of listing those specific intermediaries. So the first is to allow disclosure to prescription drug monitoring programs. There had been previous guidance issued in 2011 that basically advised states not to have information subject Part 2 submitted to PDMPs. And this reflects a change in that previous guidance. But I think one of the things one of the challenges that we're going to see with this is that it still does require explicit consent, and it also isn't necessarily consistent with the way PDMPs are managed or I guess who is connected to them, in the sense that those behavioral health providers or those SUD providers wouldn't necessarily be submitting information in the first place today. So this is a change that might open the door to future efforts, but it's unlikely to be a big change in the short term. The other change here is to allow non-Part 2 providers to access central registries. So a central registry is just as the name suggests, a registry of where people have received treatment, and it can include some basic information like medication type and dosage. And the idea of the registry is to prevent multiple enrollments for a person. And the change here is to allow not just Part 2 providers to access it, but also to allow non-Part 2 providers to access the central registry and figure out if a person's receiving SUD services. The caveats to this one are it again does require explicit consent, and my understanding is we don't have central registries currently in Washington. So this is another one that is unlikely to result in significant changes here in the short term. Another change is that they are further expanding when information can be shared in response to a medical emergency, and the way that they're broadening that is to specifically acknowledge that it may not be possible to gain consent when there's a declared state of emergency in response to a natural disaster. And so in those circumstances, you'd be able to share information without consent, and that is more aligned with what is already allowed in HIPAA. And then the last one I wanted to touch on here was that it clarifies the audit and evaluation disclosures that are allowed. And to provide a little personal commentary on this, right now the rule allows audits and evaluations and doesn't have any real definition of what an audit or evaluation is. And there's broad disagreement about how that should be interpreted and how broadly it should be interpreted. And what SAMHSA is saying is that they intend for it to be broadly interpreted and include not just what we would think of as like a typical audit function, but also a whole range of evaluations, including looking into care quality type things, exploring like the effectiveness of value-based purchasing and those types of much more general evaluations. So I think that's going to be an interesting one to watch. It is certainly much broader, or at least what's in the rule is much broader than what's currently in the rule. But there are still some tricky questions about how that's going to be implemented in practice, and there are still lines that are going to have to be drawn somewhere. So the last section that we're going to talk about is electronic consent management and kind of the actual tools to facilitate the exchange of information. And Amber's going to handle that, but before I turn it back over, do we have any questions?
Yes, we have had some questions come in. So I'm just going to go through them in the order they came in. So the first question kind of concerns health information exchange, specifically collective ambulatory, what used to be known as pre-manage. So there's been a big push within King County and across the state to get providers signed up with collective ambulatory so they can get alerts when their patients are in the emergency room. So here's the question. If you're a provider considering using collective medical's consent functionality, has the HCA vetted their consent model where the HCA could support providers in the use of collective's platform?
So we have not formally vetted it, and we can't endorse it, but I don't want that to be interpreted as meaning that we don't support it. We're aware that Collective is taking that on and has launched a program to start managing consent for those services, but it's not something that we've actively, I guess, reviewed or can endorse either way. For now, I just advise people that that consent management solution should comply with the consent requirements that are laid out in the guidance, and hopefully the guidance has those requirements in a clear enough manner that can be a pretty easy review.
Okay, great, thank you. Yeah, and the next question is, would contracted scribes fall under the qualified service organizations category?
So I assume there that we're talking about somebody who's working within the Part 2 program along with the actual provider who's providing substance use disorder services, and the answer there would be yes. That'd be a scenario where you could share information without explicit consent. because they're part of kind of that care delivery system for the provider itself. But you might need to have a specific agreement with them, like a qualified service organization agreement, which is similar to a business associate agreement.
Okay, great. And on to the next question. Does the law allow third-party redisclosure of documents received from outside entities, such as lab results?
Can you say that again?
Does the law allow for third-party redisclosure of documents received from outside entities, such as lab results or tox screens?
I think that is one where the specifics are going to matter a lot, and it might be a little bit of a case-by-case determination. Probably a good example would be prescription information, that if you have someone who is prescribed a medication by a Part 2 program, but then it's filled by a pharmacy that doesn't have affiliation with that Part 2 program, and where the information doesn't necessarily reflect the fact that the person was treated for an SUD at that Part 2 program, then it's not going to be subject to the law. But it really is going to be a case-by-case situation. And it's also going to matter who ordered that lab. So like it goes back to the question of who is subject to it in the first place. If it was the Part 2 program that ordered the lab and then it's shared with like a primary care physician, it's much more likely to be subject to the law than if the primary care physician is the one who orders it in the first place. In that scenario, I feel pretty comfortable saying it's not going to be subject to Part 2.
Okay, great. And the person who asked that question just sent me something else. To clarify, we're specifically being asked to disclose these to DOC. I assume that's Department of Corrections.
I would encourage that person to go back to the question of whether they're subject to Part 2 in the first place.
Okay, great. Yes, thank you. And then the last question is, what happens if a substance use disorder provider did not obtain proper consent, and then an organization within their HIE received a patient's SUD information?
So I think that's getting to what are the consequences. I mean, it certainly could. It sounds like that in that scenario, 42 CFR Part 2 would have been violated. There are not, to my knowledge, existing cases of enforcement by the federal government. So this is something that everybody's trying to implement, but there hasn't historically been much in the way of enforcement, or there aren't. The regulation doesn't have much teeth, I guess I would say. But this is something that isn't necessarily going to stay that way forever. And I imagine as we continue seeing regulatory changes and we continue to see this law debated in Congress, that may be something that's subject to change. And obviously, if that does happen, I'd encourage whoever is participating to do what they can to correct the mistake.
Okay, great. Thank you for that. So I will turn it back over to you since we've got just 10 minutes left.
Great, thank you. So I get the pleasure of closing out this session with you all, and this is, I think, a nice capstone to the conversation. So we've talked a lot about the benefits of a general designation and how that really optimizes the integration of behavioral and physical health integration and allows for that smooth transaction of records. But how do you do that in a world now where we might not all yet be integrated in our electronic record exchange? So as you probably are all aware, there's no consistent or one gold standard in consent management across the country, but there certainly are some best practices and principles. And we've talked about some of these maybe in a little bit different flavor earlier in the conversation, but those include transparency with the patient, so ensuring that the person receiving services is directing how and when their records are shared. And also, the solution needs to be able to easily integrate into providers' workflows. And the system needs to be scalable and sustainable. And we found that in order to do this, standardization is required. So standardization is really the key to that scalability. And that's what we've chosen to focus on as part of this project. So similar to early contemplations of the project, here's some key questions and decisions that we wrestled with as we were working on developing technical requirements for an electronic consent management solution. So you can see that there's important decisions outstanding on who manages the consent. So is it through a provider portal or a patient portal? How does someone revoke their consent? Who uses this tool? Again, is it an app on the person receiving services on their phone, or is it through a laptop in the provider's office or integrated into their EHR? What information are we asking persons to consent for, and then how is that shared, and how granular is the consent? Is it to the visit, to the type of data, to the data element? So all of these things were considered as we move forward in development of technical requirements. So here's an example of a high-level workflow, and I won't get into the nuts and bolts of this, but this was one of many workflows that were evaluated when we were developing technical requirements for a consent management solution. So you can see key decisions included where the consent is gathered, how the substance use disorder information is stored and where it is stored, and then how the provider gets access to that information. As mentioned, integration into provider and clinic workflow is of utmost importance. So unless we can standardize that and make that easy for the providers, it's not going to happen. So here's an example of a model that we worked with some provider groups on integrating the consent conference and assignment into their workflow and EHR systems. So where are we? I'm happy to say that we have embarked on this journey. The slide was developed before we had secured funding, and we have successfully secured funding for the pilot portion of this project. And so we're right in the middle of steps 2 and 3, where we're gathering requirements, gathering additional requirements, and then evaluating whether it's best to build, buy, or partner. And we want to ensure that we have an iterative design structure where we can pilot, and the decision has been made that we will pilot with the use case of 42 Part 2 in exchange of substance use disorder information, but that we want a solution that could scale beyond 42 Part 2. So as mentioned, we have secured federal funding through the Support and Partnership Act, and are securing a contractor for that project oversight. And that contractor will be helping us to review our existing requirements, continue to finalize those requirements, and then go out for a system design and initiation of a pilot. So thank you so much for your time today. Are there any last-minute questions?
Yes, so there have been a couple kind of as follow-up questions, and I offered to circle back with folks after the webinar, but since the topic of jails, Department of Corrections has come up in a couple places, I wanted to ask and see if you could respond in the few minutes we have left. So it sounds like some of our providers, when they're working with patients who are touching the jail system, the jails are saying that those individuals don't have any privacy rights concerning this SUD information and that the information can be disclosed under HIPAA. What would be your advice for our clinical partners who are working with jails?
So you'll see that the guidance is a little bit silent on those exact interactions yet. So we know that this is a place for further investigation and development. I would advise that we would have a subsequent conversation so that we can better understand the request and the exchange relationship, and we'd be happy to enter into an offline conversation around that use case.
Okay, fantastic. Thank you. And that was it as far as questions.
Great. Thank you all.
Okay, and a big thank you to Matt and Amber for sharing this important information with us. Yeah, I know our webinar ended up taking the whole 90 minutes, so thank you so much to everyone who stayed with us today. And we'll be in touch soon about Healthier Here's next partner learning webinar. It's going to be November 8th, and it's about community health workers and community health worker supervisors asthma training. So we'll be in touch about that soon. And another big thank you to Matt and Amber for spending their lunch hour with us. Thank you both.
Thank you.
Thank you.
Okay, thank you to everyone who participated. We'll be in touch soon. Take care.